with that, we're very grateful for Dr. Stanley Chen Cardenas, if I'm saying that right, joining us to talk about adrenal insufficiency. I can tell you this is always of great interest. We think that with all the neuro complications, they're like, just take some Cortef, no big deal. Adrenal insufficiency is a big deal, so we really are grateful for you coming to talk to us.
Okay. Well, first of all, thank you for inviting me, and I'm very happy to be here. I think that we have heard throughout the days that adrenal insufficiency is a major part of ALD, and Robert actually did a pretty good job at introducing to the audience what I'm going to talk in a little bit more details and hopefully clarify some of the concerns and some of the questions that you have. So I'm an adult endocrinologist, so most of my experience is in adults, so may not be able to tell you much details about pediatrics, but hopefully I can guide you in that as well. So I'm going to try to give a little bit of an introduction with describing some of the symptoms and how we diagnose the condition and some of the important aspect of management, and then touch a little bit on some incoming new therapies in adrenal insufficiency. So AI, I'm going to refer to adrenal insufficiency as AI, not artificial intelligence. So it's very common in ALD. And just to give you a little bit of a perspective, I put this slide, I don't know if you can see my arrow here. The prevalence of adrenal insufficiency, primary, and I explain what do I mean by that, in general is not common. It's about 15 to 20 on 100,000, which is not that common, and that may be the reason why often you see physicians not being very aware of this condition. ALD represents part of this, so it's even less common, so that's part of a reason of that. So to give you a little bit more stats, ALD is the most common cause of primary adrenal insufficiency in boys less than 15 years of age. And if you look at overall, adrenal function is abnormal in the majority, about 90% of symptomatic ALD boys and 70% of men with AMN, and it's usually normal in most females, okay? But what is adrenal insufficiency? How we define that? So adrenal insufficiency is a condition that is characterized by a decrease in adrenal hormone production. What hormones are those? Most commonly cortisol, less commonly aldosterone, but there's also a little bit of androgen production in the adrenal gland. So that's also another area to look for. So how does it work? And in the previous talk, there was a conversation about this, but let me review this in a little bit more detail. So the adrenal actually work together with the pituitary gland and the hypothalamus. Can you see my arrow in both sides? Okay, so here is the nervous system. If you can read here, there's a hypothalamus. In the hypothalamus, there is a hormone that is called CRH, which stimulates the pituitary gland to produce another hormone called ACTH. And ACTH goes to the adrenal gland to stimulate the production of cortisol. And cortisol also gives feedback to the same organs, the hypothalamus and the pituitary, and they work as a negative feedback. So if there's too little cortisol, there's going to be high ACTH, and that's what you see in ALD patients with adrenal insufficiency. So this is all tightly regulated, and there is also a daily pattern of cortisol production where it's highest in the morning and then goes down towards the rest of the day. And you can see here that this is all driven by a hormone ACTH in the central nervous system. So when the ACTH or the pituitary fails, we in endocrinology call it secondary adrenal insufficiency. When the damage is in the adrenal gland itself, we call it primary. So in ALD, we're talking about primary adrenal insufficiency. And that's very important that you tell that to your doctors, because in primary, as opposed to secondary, in primary, there's very little amount of cortisol remaining. And that predisposes patients to higher risk of adrenal crisis, okay? So in studies that have been done trying to quantify how much cortisol a human being or an adult produce over 24 hours under basal conditions, it's about 10 milligrams a day. And if you think about it, many of you take hydrocortisone, and you're taking about 15 to 20, 25 milligrams in a day. That's trying to account a little bit for the absorption of the pill. So roughly the body needs about 10 milligrams, and a little bit more that in the drug form. So if we zoom into the adrenal gland, it has two major parts. We say the cortex, this is this area, and the medulla. So the cortex is the one that is primarily affected in ALD. And if we take a slide or a piece of the cortex and we look into under the microscope, we'll see different zones. There is one here in the top called the zona glomerulosa that produces a hormone called aldosterone, and that hormone is in charge of regulating blood pressure and sodium in the body. Then there is another zone called the fasciculata that basically produces cortisol. It's the largest zone of the adrenal cortex, and that's the one that is mostly affected in ALD. And then the other zone is called the zona reticularis that produce androgens. So in ALD, it has been extensively discussed that there is accumulation of very long-chain fatty acids in the cells, and that essentially damage the architecture of different organs, in this case the adrenal gland. And there are some pictures here, some fibrosis that appears as a consequence of these fatty acids, and some electron microscopy showing some disruption in the architecture of these cells. So what are the symptoms of adrenal insufficiency? And symptoms you would see that are very non-specific. For example, if you see here on the left, you see loss of appetite. A lot of things can cause loss of appetite, weight loss, nausea, salt craving. Salt craving is a very specific sign, and we look for that. If you're craving salt constantly, that could be a warning sign for primary adrenal insufficiency. Dizziness, also not that specific. Low blood pressure, that also happens in adrenal insufficiency. And I'm going to move to the right side. Depression, fatigue, low libido, diarrhea, vomiting, abdominal pain. Again, if you think about it, there are so many common things that can cause this, but we have to have low threshold for detection. One clinical feature that we look at is hyperpigmentation. And this is a feature that was well explained by Robert that has to do with the elevated ACTH/MSH, the two hormones that goes elevated in the setting of primary adrenal insufficiency. And I have also a picture here, and those hyperpigmentation areas usually occur in you see here in the knuckles or in the skin fold areas, also in the mucosa, like in the you can see here some dark spot above the teeth in the gingival area, in the tongue, also in the vaginal mucosa. That can be a sign also of primary adrenal insufficiency. If you do blood work, you can see things like anemia. You can see low white cell count, high eosinophils. You could see low sodium. You can see low blood sugar and high potassium. So there are multiple things that all together can make us suspect this diagnosis. Now, how we confirm this diagnosis, this is the clinical part first, and then we do through a blood work. So in order to confirm or to look for adrenal insufficiency, you do a blood work that is done between 7 and 9 in the morning. And the reason for that is that cortisol should be the highest in a normal individual at that time of the day. So if it's low, when it's supposed to be high, that's more discriminatory of a test. So you get the blood draw, you get a cortisol, and normally we do it together with an ACTH. So a low cortisol along with an elevated ACTH makes this diagnosis. But what happens if someone has cortisol that are kind of borderline or they're not definitively low? We can do a test that is called ACTH stimulation test or cosintropin stimulation test. And this test is basically getting a blood work after you get an injection of a hormone called ACTH. And we get a blood draw at 30 minutes and then at 60 minutes after injection. Let me put an example here. Let's assume that we suspect that a patient can have adrenal insufficiency because he's having nausea, vomiting, he's dizzy, or he's not feeling well, he's losing appetite. So we do an AM cortisol. So the AM cortisol can be more than 12, and this number can vary quite a lot because it depends on the assay. For some assays, like for example mass spectrometry, we can tolerate even 10, sometimes 9.5. It all depends on what assay you utilize. If you use an immunoassay, you can say 15 or 13. So don't get to work with your endocrinologist on that. Okay. So if it's in this example more than 12, the cause must be something else. It's not adrenal insufficiency. So what if it's less than 3 in this assay? It confirms that the patient has cortisol deficiency. So what if it's between 3 and 12? This is where we do the cosintropin or ACTH stimulation test. And if we see a level that at 30 minutes or at 60 minutes is more than 15 or 18, it also excludes this diagnosis. Then if it's less than this, it confirms the diagnosis of adrenal insufficiency. Okay? So These together with an elevated ACTH would say this is primary adrenal insufficiency, and in the setting of ALD, this is most likely the cause for that. Okay? So we have talked a little bit about clinical presentation, diagnosis. Now, what about management? And this is very important here. Most patients with ALD and primary adrenal insufficiency, they need glucocorticoid or cortisol replacement. Only about 50% needs mineralocorticoid or fludrocortisone replacement, or aldosterone replacement is the other name. So most commonly we use hydrocortisone, and the doses are between 15 to 20 to 25. I was saying that in pediatrics, it's dose based on body surface area, so the bigger the individual, the higher the dose. But in adults, generally we use a dose between 15 and 20 to 25. And this is in divided doses in the day. We use the highest doses in the morning, because that's what normally your body would do, and then the smaller doses in the early afternoon. We don't use hydrocortisone after 4 in the afternoon, because that can affect sleep. So don't do the second dose after 4. And we tend to divide it into 2 or 3, depending on how the individual feels, because this medicine has a short half-life, so it can wear off quickly. Another option that is less physiological would be prednisone. Some of you may have used prednisone. It's only 5 milligrams once a day, but it's does not resemble that curve that I showed you earlier. For those that require aldosterone replacement, the medicine is called Florinef or fludrocortisone, and it's used in doses between 0.5 to 0.2 milligrams for once or twice a day. Now, there have been studies looking at, should we replace the androgens that are produced in the adrenals? I'm not talking about testicles, but I'm talking about adrenals. And the answer is no. The studies have been very disappointing, and there's really no good evidence for using a medicine called DHEA, dihydroepiandrosterone. So no reason to use that. So this is what we do from the previous picture. So we replace aldosterone by fludrocortisone. We replace cortisol by hydrocortisone or prednisone. There are other steroids, but they are not as good as these ones. And then, as I said, DHEA, there's no enough evidence. And this is what we try to do. This is an example. In yellow, you see here what the cortisol levels do over 24 hours in normal individuals. Here you see the nighttime, you see the daytime, and again the nighttime. And here you see cortisol levels on the y-axis. And you see that by giving the drug either 2 or 3 times a day, in this case 10 milligrams in the morning, 5 milligrams around noon, and 2.5 milligrams early afternoon, we kind of simulate the same circadian pattern that cortisol does. And most individuals do well with that. So what's important to know also about this is that if you give too much or you take too much steroids, you can have complications. So treating, how do you know that you need more? We generally tell patients that if you have a stressful event, you can take additional steroids, but you have to be cautious what is a stressful event, because sometimes there's psychosocial stress, sometimes there's physical stress, sometimes there's acute illness. So you have to work closely with your endocrinologist on how to define that to avoid being overtreated, because overtreatment can lead to high blood sugar. So if a patient has baseline diabetes, that can get worse with too much steroids, can lead to worsening high blood pressure, high cholesterol, and if you use doses that are too high, it can even lead to opportunistic infections like fungal infections, risk for clots like DVT, PEs, or pulmonary embolism, peptic ulcer disease, and weight gain, among other things. This is how excessive cortisol would look like, but this is extreme. This is not usually at replacement doses. You see there's a prominent abdomen, there's thin extremities, but this is the other extreme of too much cortisol. Usually not in the case of primary adrenal insufficiency. So important in part of the treatment is how to prevent crisis, because this is what can compromise life. This could be life-threatening. So every patient with adrenal insufficiency should know the sick day rules. And what do I mean by the sick day rules is I should increase my dose of hydrocortisone or steroids by 2 times or 3 times if I have acute illness like a cold or a sore throat or a fever. And I'll give you some additional information about that in a few slides. So the sick day rule is important to also to anticipate stressors. For example, if you know that you're going to have a surgical procedure, you're going to have your gallbladder removed, or you have a hernia repair, surgical procedures require more of the stress response. So you have to tell your doctor to tell the surgeon or to tell the other colleague by how much to increase this in order to respond and have a good outcome from your surgery. If you have an acute illness that part of it includes nausea or vomiting, and you're not being able to take the pill or maintain the pill in your GI tract, and you see that you're vomiting the pill, you need to get an injection. So in those cases, it's important that you have a hydrocortisone kit and go to the emergency room, because that puts you at risk for adrenal crisis. So this is an example that I want to show you. In the left side, you see in what color is this? This is green. You see here this line. This is, again, another curve showing the cortisol circadian pattern. I call it circadian when there's a cycle of 24 hours. And here on the right, you see what happened with cortisol level during cardiac surgery. This is a group of patients with CABG, cardiac bypass graft. And you can see here in green that the area under the curve, or the amount of cortisol that they require compared to the one on the left, is much higher. So if this patient, for example, does not increase their dose of hydrocortisone during that procedure, it may go to an adrenal crisis, which is typically characterized by hypotension or low blood pressure and even shock. And if you wait too long, it may not even respond to treatment, which is very, very serious. So going back to the recommendation, 6-day rules, which means doubling or tripling the dose of hydrocortisone for 2 to 3 days. For example, if you're taking 10 milligrams in the morning and 5 in the afternoon, you can take 20 and 10 for 2 to 3 days until you feel better. And then you go back to the previous dose. So we spoke about the hydrocortisone kit. Everyone with primary adrenal insufficiency should have a hydrocortisone prescription to inject themselves, and then the plan should be to go to an emergency room. Don't stay at home if you do that. Also, everyone should have a medical alert bracelet or necklace, because if God forbid, you're unconscious and EMS sees you and see that bracelet, they can give you a steroid shot, a hydrocortisone shot, and that can save your life. So that's very important for every patient with adrenal insufficiency. And for those that are using fludrocortisone or Florinef during very hot weather or physical activity, intense physical activity, the dose of fludrocortisone can be double or can be increased during those period of time to compensate for the activity. So to finalize, there are some therapies in development. There are some modified release hydrocortisone, which basically, instead of taking the pill multiple times of the day, try to simulate that circadian pattern that I show you by self-releasing the amount that it's needed at specific times of the day. That's still in development. And then the other one that has been also looked at is a hydrocortisone pump, which is like an insulin pump. For those of you that are familiar with that, is giving in a subcutaneous form hydrocortisone in a continuous way, just trying to mimic exactly that pattern of cortisol production that an individual without adrenal insufficiency would have. That's very helpful, but for those patients that have problems with absorbing the pill or absorbing the medicine, but are still in development. I know that some endocrinologists have used this off-label, but still there's a lot of tweaks that needs to be done. So I want to end here to allow some time for questions, but as I said before, AI, and you all know, is very common in ALD. It's important to recognize it and to treat, to prevent all the complications associated with it. Mostly the hormone deficit is in cortisol, but some of patients may need aldosterone replacement. Avoid overtreatment and discuss your questions with your endocrinologist. And if they are not familiar with the term adrenal leukodystrophy, or they don't think about it, just tell them primary adrenal insufficiency, and most endocrinologists would know what to do, and most physicians should know what to do. And also long-term follow-up with a multidisciplinary team that includes endocrine is an important part of the management of ALD. So I'll stop here to allow some time for questions.
All right, any questions? If not, I have a few. Wait.
Hello, thank you so much. Excellent presentation. My question is, I see in the adrenal insufficiency communities sometimes an uproar or concern about either availability of cortisone or different brands of cortisone that work better. Is that something that you see in your practice, and is there anything that patients can do to kind of stay ahead of the curve?
Yep. So good question. For cortisol as a pill, I haven't seen a shortage or any problem with that one. The injection was in a shortage over the last year. And for example, for those with pituitary or secondary adrenal insufficiency, companies have been trying not to approve it or to avoid people from getting it. But for primary adrenal insufficiency, it's completely indicated. So I haven't had any problem with primary adrenal insufficiency. Yeah.
Hi. That was a really useful and excellent summary and presentation.
Thank you.
One question, and when do you find the AM cortisol and ACTH enough, and when do you choose to do the ACTH stim test?
Could you repeat the first part of the question?
Sorry. When is just the AM cortisol plus ACTH test enough? And when do you order the ACTH stim test?
Oh, great point. So if you get a morning cortisol and ACTH and they are diagnostic, meaning that your level is very low and the ACTH is elevated, you have the diagnosis. You don't really need a stimulation test. But when the numbers are indeterminate in between, let's say you get a morning cortisol of 7.5 and you have some fatigue, tiredness, dizziness, then you want to make sure you're not completely sure, you have some degree of cortisol production, then you can stimulate the glands. So the amount of ACTH that we give is 250 micrograms. And to give you an idea, that's huge because that results in plasma levels close to 1200. And the upper range of the normal in most assays is anywhere from 50 to 75. So that's a big stimulation. So if you don't respond to 1200 of ACTH, your adrenal glands are not really working. So that's what the ACTH stimulation test is supposed to.
Other questions? From online. In the meantime, if you can answer, have you had experience with Plenadrin for people in Europe because it's not approved in the U.S. Because it seems like the modified release people feel better. Any comments on that?
No, I don't have personal experience, but I've seen anecdotal experience from patients that they feel that it's easier or simpler, but cannot comment more because I haven't had personal experience with it.
Okay, wait, and online?
It's a modified form of hydrocortisone, Plenadrin.
Someone online shares that they went 6 years since being diagnosed with AMN and Addison's before learning that they also needed fludrocortisone, and asks, should all patients initially have their aldosterone tested?
That's an excellent point, and I didn't mention that. I would say yes, because that's the only way we can really find out. And the way we assess for aldosterone deficiency is we measure aldosterone, we measure something called plasma renin activity, and at the same time we measure electrolytes, including potassium. So a high renin level and a low aldosterone would make the diagnosis of aldosterone deficiency, and that's something that we should also do at the same time. But it's less common in the setting of ALD. Yeah.
Got it. Thank you. And then a few people online have asked if the use of testosterone has been studied in male ALD patients or AMN patients. And can you take testosterone if you have adrenal insufficiency?
Yep. So there are hormones, so definitely if you have testosterone deficiency, you can take testosterone along with the other hormones. So they are all replacing what the gland would normally produce. So there's no contraindication for that. In AMN population or in ALD in general, I'm not sure if there's good data on what percentage of patients develop testosterone deficiency, but if it's low, you should treat it. There's no really any reason not to. But if the levels are normal and patients have symptoms, and not infrequently we see erectile dysfunction, not infrequently we see problems with fertility, that should be addressed, but that should look into the cause that is actually producing it, not necessarily low testosterone. But yes, if it's low, there's not really any contraindication for treatment.
Hi. Sorry, over here. So if so my son has primary adrenal insufficiency, he's not taking fludrocortisone. Would you generally test the renin again? You know, how would you, it's not that they don't need it, so we'll never need it, or?
So what I would do is at the beginning, at the initial workup, I will do it. If it's normal, I will perhaps screen initially at 6 months or then at the year. And if things have been normal for a good amount of time, I can look at it clinically. I can look at, for example, blood pressure. If his blood pressure is not low or is normal, there's really not an indication to screen. You can also look at electrolyte. Potassium is a good indicator of it. A high potassium suggests that aldosterone is low. So we can also look at a normal labs and have some sort of idea of how his aldosterone is doing. But I would, at least at the beginning, make sure that he does not have aldosterone deficiency.
This is more, thank you for all your information. I am a new mom to stress dosing. And one of the things and I don't know if anyone else is new and knows this already, but just how long it takes the steroid to get inside of you. I think hearing if you throw up, you have to give yourself a shot and go to the hospital is a little bit of a dramatic, maybe.
Well, I would say you have a couple of, you can do that for a day or so, but if you see that that's being consistent, I would go to the hospital.
Yeah,
sooner than
I think
later.
there's always a little confusion of
Yeah.
when to give yourself the shot
Yeah.
and to go to the hospital as a new patient.
I mean, just to confirm, at least the way I understood it is once, if you take your cortisone and you don't vomit for 30 minutes, you've got enough in the system that you don't have to start injecting. Is that a good rule? I just want to make sure people hear, like, when do they have to start with the shots or not?
Yeah, it's pretty rapid. The absorption is pretty rapid. Yeah, within an hour you have enough to maintain function.
So can I ask for a question in terms of, some of the patients are diagnosed, this kind of goes to Karen's question, and initially they look at the cortisol levels, aldosterone levels, and they kind of get on a regimen for life, so to speak. But then, I've seen where all of a sudden there is a little bit of cortisol, or things change, and then maybe they're hypertensive. So, which again could have other causes. The reason I want to ask about that and what your view is in terms of how to really manage it and what you should look for is, I'm sorry Josh Bonkowski's not here, but when he was here yesterday, he was showing all the data where he looked at ALD men versus control, and there were all these other comorbidities like hypertension, like diabetes, and my bias, totally, this is without data, so I want him to look at it, is a lot of that I think is tied to adrenal insufficiency as opposed to something else with ALD. So can you maybe comment on that? Because I don't think I just personally don't think we really manage adrenal insufficiency as much as we manage everything else, because it could be a silent killer.
Right. So I think it's important to reassess things over time. I have patients that they have primary adrenal insufficiency and they become hypertensive over time and they are getting swelling in their legs. So that's a time where when you see that, that's a time to reassess. Does this patient really needs fludrocortisone, for example? Is this making him more hypertensive or he's retaining more fluid because of fludrocortisone? Because those are the side effects of the medicine. And if you see a patient with primary adrenal insufficiency and it's gaining weight, and you're giving a dose of, let's say, 15 milligrams and 5, is it time to say, maybe he needs less? Patients lose weight, and remember, cortisol is dosed based on body surface area, so if patient's weight is changing, should I reassess and lower the dose a little bit? So if someone develops osteoporosis, should we take a look and try to maybe minimize the exposure? So all those things we keep in mind, and we try to minimize the exposure. Because, again, it's possible that some of the adrenal glands are still producing some amount of cortisol or aldosterone. So that's important. That's a great point.
Any other questions?
I'm sorry, did you talk about emotional stress at all?
Yes, but the difficult part with emotional stress is how each individual cope with stress. It's hard for me to tell a recommendation across the board. For example, there are certain situations that for someone can be very stressful, but for the same situation for another person may not be as stressful at all. So this is where individual interactions with your endocrinologist have to come in place. But yes, I've seen patients that with emotional stress, they feel that they need more, but they take extra pills, that they get a lot of stress in the job. They have a 16-hour job, and they need to take extra for that particular day full of meetings. We do that, but try not to expose the patient to a lot of steroids, because in the long term, that's going to affect their bones, that can affect some other things that we really try to avoid.
Yeah, but I really appreciate your presentation, because I've talked to endocrinologists who said, no, you don't need steroids for emotional stress. I can tell you there was one time in my son's life, he took some major French exam, and he literally had a physical reaction. And I said, you know what, just take 5 milligrams. And all of a sudden he felt better. And he was sitting in a chair, so it was clearly emotional, not physical. And then endocrinologist was like, no, there is no. I think each patient is, I'm sorry, you're the physician, but just from the parents and the people, we're the ones that live with it, and everybody is so different. That's kind of where, I loved your presentation because you gave such a range. Everybody is so different, and you kind of have to see what's normal for that person. So,
Sure.
Any other questions? Thank you, really. We're so grateful for you being here.
Thank you. Thank you. Thank you.